Hi, I'm Patrick Dunnican. At Gibbons, we believe that citizens need to be informed about the complex issues that affect their lives. That's why we're proud to support the programming produced by the Caucus Educational Corporation and their partners in public television.
The complex world of healthcare next on Caucus, New Jersey.
Funding for this edition of Caucus, New Jersey has been provided by New Jersey Manufacturers Insurance Group, auto insurance, homeowners insurance, and banking under the principle of stewardship. Wells Fargo. The Healthcare Foundation of New Jersey, founded by the Jewish community. And by the Merck Company Foundation.
Welcome to Caucus, New Jersey. I'm Steve Adubato. Right here in the studio to discuss the complex and ever-changing world of healthcare is a distinguished panel of experts, including Mary O'Dowd, who is the Commissioner of the New Jersey Department of Health and Senior Services; Rich Miller, CEO of Virtua, a health system located in southern New Jersey; Barry Ostrowsky, President and Chief Executive Officer of Barnabas Health; and Annette Catino, President and Chief Executive Officer of Qualcare, a managed care company. And Annette is one of the board members of the Caucus Educational Corporation. Full disclosure, they happen to produce this program. Thank you all for joining us. Commissioner, complex world of healthcare, is that accurate?
I would say yes.
And confusing?
It can be.
Why?
Well, it's ever-changing, and I think in particular now we have a number of different things going on in our healthcare system that are really creating some dynamic change, and I think some of the players in this room are examples of that.
It's the whole idea. I mean, you pick up any publication, you look at websites, you try to follow the industry. One of the biggest areas, mergers, consolidations. Oh my God, for-profit, not-for-profit. Is that, Barry, the dominant theme? A couple of years ago, it was charity care. That's all we talked about. Is this the dominant theme now?
I think for now, it's a very significant topic about consolidation, because I think all of us in the industry are trying to find the right level of efficiency to support the rendition of excellent clinical care, and frequently size matters. So if you become bigger and you're able to share the expense over multiple venues, you're in a much better position to deliver care more efficiently. I think, unfortunately, much of the discussion right now is about efficiency as opposed to clinical excellence, as opposed to productivity, and frankly, as opposed to better lifestyle living that we've talked about in the past. But right now, the topic that has everyone stirred up is this resource efficiency issue. And there's not been enough discussion about quality, I think, of clinical services.
Jump in, Rich.
Well, I agree with Barry. I think the economics are driving the change, Steve, frankly. The economics in Washington are changing. Medicare funding's changing. Medicaid funding will change. Frankly, healthcare is too expensive for the business community as well. So I think the economic dynamics will force change in the delivery system, and the delivery system being how we deliver the product in New Jersey. So we're going to have to be thinking differently about healthcare product, how it's delivered more effectively to the consumer, more health and wellness involved, caring for chronic disease differently. Those things have to be dealt with.
And then haven't we been doing this for a long time? I mean, I always keep thinking, you joined us, you were telling me recently, last time you joined us was, I don't know, 15 plus years ago. And I keep thinking that we've talked about the healthcare crisis. We've talked about these critical, impending challenges and issues. What's different?
Well, I think what's different is we've just come through a very tough economic period for the global economy. And so there's been a focus on how can we do more with less. When there's no money, the federal government doesn't have any money, the state governments are all, looking for more money, and the employers who've all had to cut back to just survive. So when they look at their expenses and they look at their health care benefit expense, and they see that that has been rising for the last 20 years at double-digit inflation. We haven't had a double-digit inflation rate in this country in the last 10 years. So when you look at health care as a single point of service, and you see that that's growing much bigger than the rest of the economy, you sit back and you say, we have to change it. We have to do something to make this sustainable for the future.
Commissioner, think about the conversation we're having right now, and think about what Annette just said in terms of there's no money, right? State government as well.
Absolutely.
Question. How do you see the role of your department and the role of state government vis-a-vis managing the challenges that hospitals face and the larger healthcare community? What is the role of the department with no money?
Well, we have a variety of roles. I would first say, the Department of Health and other state partners invest almost $1 billion just into our hospitals, and that's not including Medicaid.
By the way, explain where that goes, Commissioner.
That comes in a variety of funds. Some of it pays for, the majority of it pays for the uninsured, our charity care program. Some of it pays for the training and retention of our physicians. We have $90 million now dedicated to that. Governor Christie invested an additional $30 million last year.
By the way, excuse me for interrupting. One of our producers just said, Steve, let's not assume people understand the charity care thing. Without opening up the Pandora's box, charity care is what?
Charity care is the way that the state pays hospitals for taking care of those people who don't have any insurance, our uninsured population. So these are people who don't have Medicaid, can't qualify for Medicaid because they have some resources. Predominantly, they're our working poor. And so we see caring for that population as a partnership between our hospitals and the state.
So excuse me for interrupting, the state and the hospitals pay?
Yeah, well, we don't cover all of the hospital's costs. The hospitals in New Jersey are required to care for any patient who
by
walks
law.
By New Jersey law. And it's actually one of the most aggressive laws in the country.
And the state reimburses an amount?
We provide a subsidy for it. So we don't provide a reimbursement per case. What we do is help subsidize that cost.
Is it enough?
I would say that the hospitals might think it's never enough because it is an additional cost to them. But I would say we provide almost $700 million, and their costs are around $1 billion overall.
I said it was a Pandora's box.
It's a big benefit.
That's a big part of it, but you do more than that. Go ahead.
Yeah. One of the other things, to what Annette was saying earlier, there are a lot of fiscal challenges, but I think it's forced us to look at ways differently and be innovative. I think we have a tremendous opportunity now where many of our incentives and goals are aligned. And I think the difficult financial times have forced us into that position, but it presents a great opportunity. In the Department of Health, we've been looking at how to work smarter. Just because we've been doing things the same way for a period of time doesn't mean it's the best. Well, one of the things we did is for our senior population, we worked collaboratively with the Department of Human Services on their program for senior nutrition benefits. We have a pharmaceutical benefit for low-income seniors, PAD, and Senior Gold. And what we used is that data to ensure...
That's the pharmaceutical assistance to the aged and disabled.
Correct.
Right.
And Senior Gold.
Right.
And what we did is we used that data that we had on their income levels to automatically enroll them in a senior nutrition assistance program, and we enrolled thousands more seniors who needed that benefit. And that brings us back to healthcare, right? So if you don't have good nutrition, then your healthcare is not going to be the best place to start. And so that's just a very simple example of how we try to use technology to improve the healthcare of our seniors. And I would say technology is another thing that's very new.
And by the way, Rich, you've talked about that a lot, using social media, because down at Virtua, by the way, you have that pin on, celebrating what?
25 years.
At Virtua, right?
Yeah, getting old, Steve.
Well, we're getting old, but you may be saying that Virtua, but I'll tell you what.
Seasoned.
I do know that one of the things that you're doing is that you're using Twitter, you're using Facebook, you're using video, you're communicating in different ways that you never have before, having to do with serving consumers, healthcare consumers. How so?
That's correct, Steve. And what we're thinking about is, first we look at our employees. We have 8,500 employees and family members. And we're just using social media and a network, our own Virtua network, to really talk about health and wellness. For example, we're self-insuring our employee population. If we can realize that we can lower the cost for our employees, not use Virtua services for health care, but get them healthier, so treat chronic disease like hypertension, type 2 diabetes, asthma, things of that nature. We've cut our fitness center rates in half. We have 3 fitness centers. The rates are cut in half for our employees. We're providing nutrition support to them. All of these things to promote wellness and prevention. A lot of people are enrolling, and we're going to gauge and we're going to measure how employees are responding from a health perspective. Are we lowering our costs?
That's interesting because, Barry, in our one-on-one conversation, you talked about some of this. Before I go back to Annette, real quick, because I don't want to assume that people are going to get to see the other one, hopefully you will. Real quick, because you've talked about wellness, whether we call it that or not, dovetail on what Rich was just saying. You pushing this issue of wellness and health healthier living as well.
Yeah, I think it is. Thanks, Steve. And I think Rich is right. I think it's part of our mission. I think not just delivering excellent care, but rather teaching people how to live better. Part of the leadership that the Commissioner has provided for all of us is Shaping New Jersey, which is a wonderful program.
It's called, by the way, log on to our website. We'll hook you up with the Department of Health. It's called Shaping New Jersey. Go ahead, Barry.
Yeah, so in my view, it's not just about providing sickness care. The world we're in, the industry that we have, has to invest in keeping people healthy, and frankly, that means we may not see them as customers. We're going to have to accommodate that. So I think through various ways of communication, the new technologies and social networking, I think it gives us another ability to help people live better. So it's an important part of our mission. We really hope to execute on it.
And we've talked in the past, shifting gears, and by the way, when you bring healthcare executives together with the Commissioner, you never really know where the conversation is going to go. It's not a very linear conversation because there's nothing linear about this debate or this discussion. And it's interesting, you get Democrats and Republicans, conservatives, liberals, you can predict that conversation. It just doesn't solve problems. And we've talked about this before. You've often said that you feel that there are times that those in government, policymakers, politicians, and others are talking about healthcare. They don't know what the heck they're talking about. And they don't really have a sense, the Commissioner excluded.
Of course, of course.
That they really don't have a sense of the consumer, of employers, and what we're really talking about and what is necessary. I'm putting you on the spot. It's what I do. Elaborate.
Well, I think you're right, and I do think present company excluded. You know, we've had a hard time in New Jersey trying to focus on things that will improve the system of healthcare. We focus on an individual item based on an individual constituency that raises a flag, that, mammograms aren't going to be covered under the age of 40, or, we need hearing aids covered for people over the age of 60.
And we get obsessed about that.
And we get obsessed about
What's wrong with that?
Because healthcare
Because we in the media love that. We can hold on to that. We got an issue.
Because you can always find somebody passionate about that issue.
What's wrong with it?
What's wrong with it? It's about taking care of the population. It's about taking care of a community of people, and it's about getting them to understand that healthcare is complicated, but we need to help better coordinate care on behalf of patients. They don't understand half of what the doctor says to them when they're sitting on the examining table. Usually you're sitting there, the doctor tells you, I think you might have a problem with your digestive system. All you hear is problem. You walk out of the doctor's office, maybe with a prescription for the little blue pill, or maybe for a test. You don't know what the blue pill is for, you don't know what the test is going to do. And then you go down a path, and then God only knows what happens.
But Steve, I have to tell you, and I have to follow up on that, one of the biggest transformative dynamics in our industry is we need to be in the retail business. The mentality, the mentality of institutional health care was very different over the years. We treated patients, we weren't sure that they were customers, we didn't understand that. They have questions, as Annette says. It's a very complicated field through which to navigate. And so now we have to invest by training our folks to be more retail oriented, to understand the patient who's going to have questions, to understand, well, as Annette said, so a patient hears a diagnosis or gets a suggestion, what do I do now? How does my insurance company integrate with this issue? Are there alternatives? We need folks to be able to sit down and say, here are the issues you're facing right now, here's some advice about that, and we will help you. We'll help you navigate that. That was never part of our behavior.
But Barry, that's problematic because, I'll come back to you, Commissioner, because Rich, you've told our producers that you think baby boomers have greater demands, are just more demanding, and frankly, it may be unrealistic to talk about it.
That ties right into what Barry's saying, though, frankly, because if you think about who's getting into the retail space, and I consider the retail space kind of the front end of healthcare, the primary care visitation. Look at CVS, look at Walmart, look at Walgreens. They're putting nurse practitioner models in. Why? Not because they want to be in healthcare space, they want people in their stores, but they also know that the baby boomer is not going to sit in an ED or a doctor's office for 2 hours to receive care. I'm a baby boomer, Steve. I'm not sitting there for 2 hours. I'm going to get up and leave. So I'm going to find a location that can service me better. Frankly, the primary care physician in our model today should be the coach for healthcare, should be the overseeing of the healthcare process, not treating episodic care. They should be your health coach and looking at, You know, what's your background in disease in your family? How do we coach that? How do we make sure you're nutritionally supported?
But respectfully, do we not have enough right now?
We don't have enough, but we also can use the nurse practitioner model to support that model. So we need to use other health people in that space
beyond
to
the primary care physician.
Beyond the primary
Commissioner,
care
is there
physician.
public policy initiatives that support what is being talked about right now? And by the way, you buy this whole retail thing?
Well, I'm not sure if I would call it retail. I think that that's part of it, but I would actually take a step back and say healthcare and the delivery of healthcare, often here we're talking about hospitals, is now having to become public health oriented.
Public health oriented.
Yeah, so public health has really been the venue of government healthcare, wellness initiatives, focusing on prevention and healthcare disease avoidance. And hospitals in the past have been more about treating a disease, treating a patient in particular moment in time for healthcare, a surgery, a visit to the doctor. And what both of these guys are talking about right now is not just talking about that patient going into that hospital setting for one visit, but looking at the population healthcare, the public health of the whole community. How do we make our community more healthy?
One quick example.
Obesity. Our rates of obesity in New Jersey have been increasing dramatically. Childhood obesity has tripled in the past 30 years. We're going to have a whole new host of challenges on treating that population as those children age and all of the issues that come along with that. So one of the things that Rich mentioned was reducing the rates for the gyms and their healthcare facilities. Well, trying to focus our population on maintaining a healthy body weight and reducing their obesity is actually going to improve their healthcare overall. Now, in the old world, that actually is a negative in their financial model because—
For a hospital.
Exactly.
Are you saying that that is Barnabas Health and Virtua's responsibility to promote activities and things that kids and their parents are doing to reduce obesity, even if it's bad for their bottom line?
I would say yes, but I would also say it's our responsibility, and this would be where Annette and I come in as payers of healthcare, the big payers,
right,
to change the financial paradigm. We should be paying for healthcare differently.
Right.
Okay. Now I don't understand, because they're getting paid when people come in because they're sick, and the commissioner is saying, let's stop them from getting sick. How do we change the paradigm for how they're going to get paid?
Well, we need to change the health plans. We need to make sure that insurance is
By
covering.
law, regulation, what?
Well, I always would rather us do it voluntarily than have a law put on the books.
Because you've never been for big government.
I'm not a big government person, and you know that. But I certainly think that we should do these things because it's good for our bottom lines. It's better for us to know that if we can get a child who's pre-diabetic into a system where they're going to start exercising regularly, they're going to have access to the right kind of nutritional support that they need to eat well. And we see in our inner cities, there are no supermarkets in our inner cities. Those people don't have those kind of choices. Barnabas just announced that they're trying to encourage a supermarket to come into the city of Newark.
Barry just talked about this.
That is an important part of healthcare. We don't like to think of it that way,
and what's his
is.
incentive to do that? Just because it's the right thing?
You know, right now it is part of our mission, but to your point, and the commissioner said it, there needs to be a new way to pay for health care, and included in that new way, there has to be sufficient resource so that it encourages us to keep those for whom we're responsible healthy. And I think it's out there. The model is out there. We have to do it. I don't know that it takes big government to do it. But as we've all been talking about, if someone assigned to our systems a certain population of folks, and we were told, here is a set of resources calculated to be sufficient to deliver health care to that group of people, but also, if in fact you keep them healthy and you don't have to provide service to them, that which you save should be invested in wellness. So you could craft a financial relationship that would allow you to do that. Now, it's very complicated, and I'm obviously describing it.
But doable.
But I think it is doable. But everyone has to try to do it. We have to understand what the rules are. We don't want to accept money and not provide services. Right. So we have to make sure that everyone's protected. But I think it's available. And by the way, I think eventually it's the only way for us to commit to excellent health care and a strong wellness program and live within our means.
Jump in, Rich.
No, I agree with Barry. The problem right now, Steve, is we're in between economic models.
In between economic models. What does that mean?
What I mean by that is we're still paid on a fee-for-service basis, episodic care in the marketplace.
Okay, stop for a second. I say full disclosure too much here. I just came out of your hospital.
You look great.
Well done.
A little bit too much information, there may be a HIPAA violation.
No, I wasn't going to go. And by the way, it was not a commercial for Barnabas Health, but I was just trying to make a point that I was in your hospital for a few days. And so I'm there to get something taken care of. I'm there for 5 days. You get paid for my being there. That's what you mean,
Correct.
fee for service.
Every day that you were there.
If I'm there not 5 days, but 3 days, you get paid less.
Correct.
That's fee for service.
Correct.
That's correct.
We're in between what model now?
So what model is we should be paid basically on keeping people out of the hospital. There should be more incentive to keep people well and out of the hospital. The model Barry was talking about a few minutes ago is how do you look at wellness and prevention, reduction in obesity. We should be measuring chronic disease differently. And are we providing that care in the community? And are we paid effectively for keeping people out of the hospital?
Is there any place in the country, excuse me for interrupting, Rich, is there any place in the country where this is being measured, where there's a model like this where we say, hey, because I often see people saying, that state's doing it, the so-called Massachusetts model. I don't know what that, never seems to work, but there's always some model in Massachusetts, so there's some place. That's the model. Is there another state that's doing it? Is there another place that's paying differently?
Yeah, there are pockets all over the country where payments are being handled differently, and they're usually in markets where there's been consolidation,
right,
where hospitals and doctors have come together under one umbrella,
right,
and so that nobody worries about where the money is going. Is it going to the doctors? Is it going to the hospitals? They just take the money in and they allocate it.
And there are places doing this? Are they states?
Absolutely. They're
They're
not
in
whole
states,
states. They're within
obviously.
states.
Okay.
There's certain geographies.
I'm going to complicate things dramatically. New Jersey has, I think other than Florida, Commissioner help me, one of the oldest populations in the country, right?
Yes.
Getting older.
We have a very large population of senior citizens.
How does that complicate the wellness issue?
Well, I don't know if it complicates it because different populations just need different types of healthcare services. So you just, as a healthcare provider and as a state, you look at your population and different pockets of your population. Ocean County, for example, is going to be very different than Essex County in terms of the challenges that their population have with healthcare and what their diseases are like.
Isn't cost more?
Cost is part of it, and who your payers are evolves as well. So
who your payers are?
So, for
Government,
example,
I'm sorry.
yes, Medicare for the older population or disabled population, and you'll have more private insurance in populations where you have a younger working population. So individuals who have their private insurance through their employer is going to be a little different than Medicare.
So my question really is this: is there something about New Jersey, the demographics of New Jersey, and I know that Rich is down in the south and Barry is, I can't even say you're in the north because it's spread out.
It's all over.
Say there are multiple New Jerseys for a second. Is there something about the quote-unquote multiple New Jerseys that makes dealing with our healthcare challenges more difficult, more challenging than other states?
Well, I think, yeah, absolutely. The demographics and the socioeconomic issues that we have by different geographies do make it more difficult. But I think the other thing that has made it harder to do in New Jersey is New Jersey has been a state that historically has had doctors who have been private entrepreneurs, small groups of doctors who've worked isolated. And so when they're working in their private practice, there hasn't been an incentive for them to necessarily want to work with a hospital or another institution.
Is that changing?
It's changing.
You're recruiting
and it's
doctors
changing
every
very
day.
quickly.
Excuse me. You're recruiting doctors every day. You're recruiting doctors every day.
Every day.
How you doing with that? You pulling them in? Are they starting to get the idea that they want and need to be a part of a system?
I think physicians now really understand being part of a system, Steve. I mean, it depends on the specialty. Cardiology, for example, is a specialty where doctors are becoming part of a system. And we're seeing much more. That primary care is another area where physicians are
What are you saying, Barry, in your recruitment?
Well, I think we have the same experience that Rich has, but one of the interesting things is a generational change. I think the newly trained physicians coming out of the top programs aren't interested in entrepreneurial business as a physician. They want to come work for an institution. They want the stability. Oh, absolutely. They want the stability. Many of them come out with significant debts to pay for education. So the security of working for an institution, which is what they've done, of course, throughout their training, now converts to their private practice life. So I think what's going to happen here is as that generation takes over in terms of the available physicians, they will come to us and solicit, as they're doing, employment with healthcare systems like ours, which will enable us, I think, to move towards this different physician hospital paradigm.
But I
Rich,
think, can I add? Go ahead,
Can we do
Steve.
this after? Because we're going to be off the air. But I just want to thank you all for solving the entire healthcare problem in just a half an hour.
I'd like your copay,
The
please.
preceding program has been a production of the Caucus Educational Corporation, celebrating over 20 years of broadcast excellence. And 13 for WNET, NJTV, and WHYY. Funding for this edition of Caucus New Jersey has been provided by New Jersey Manufacturers Insurance Group, auto insurance, homeowners insurance, and banking under the principle of stewardship. Wells Fargo. The Healthcare Foundation of New Jersey, founded by the Jewish community. And by the Merck Company Foundation. Promotional support provided by NJ Biz, All Business, All New Jersey, and the Star Ledger and NJ.com, Everything Jersey. Transportation provided by Airbrook Limousine, serving the metropolitan New York, New Jersey area. Caucus New Jersey has been produced in partnership with TriStar Studios.
There is a place that pushes beyond traditional thinking to take medicine further than ever before, where science and creativity work together to give heart and cancer patients new possibilities, and researchers discover options for children who once had none. A place that proves every day that impossible is just an opinion. Hackensack University Medical Center, where medicine meets innovation.
Hello, I'm Rafael P. Roman.
And I'm Steve Adubato.
Join us every week on New Jersey Capitol Report.
Because we'll ask the questions that you want and need answered.
Airing on NJTV, 13, and WHYY. Check your local listings.